What's up, Ninja Nerds? In this video today, we're going to be talking about appendicitis as a part of our clinical medicine section. And if you guys like this video, it helps you, please support us. Some of the ways that you guys can do that is by hitting that like button, commenting down in the comment section. Please subscribe. Something I really urge you guys to do, because I really think it would be beneficial for you, is to go down in the description box below it. There's a link there. It takes you to our website. On our website, we have amazing notes, illustrations, we have quiz questions that we're developing, as well as exam prep courses that are in process, and you guys can keep an eye out there. So please go check that out. A lot more to offer there on that website. All right, let's talk a little bit about appendicitis. We're going to first discuss the pathophysiology of appendicitis. So that includes going over a little bit about the mechanisms behind how it develops, talking about the causes, and talking about primarily some of the classic clinical findings that we see in patients with appendicitis or acute appendicitis. So this is one of those like medical emergencies. You have to be able to pick it up. When a patient comes in with acute appendicitis, the appendicitis is inflammation and usually infection of the appendix. It's this little thing, this little kind of like organ or piece of tissue that hangs off of the cecum. So you know how you have your large intestine? This would be a part of the ascending colon that we're taking a section out of, right? This is the ascending colon. This would be like the ileum, which is the distal part of the small intestine. This would be the cecum, and then hanging off here, off the cecum, is the appendix. Now, in true anatomical concepts, which we've talked about before, there's different ways that the appendix can lay. We're not going to focus on that. What I want to focus on is, how does the appendix become inflamed? What's the pathophysiology? What's the causes? And what's some particular epidemiological cues that can cue you off on the exam? So, first one is a fecalith. It's literally what it sounds like. It's a poop stone. So this is usually something where you have like hard, like fecal material. And what happens is it kind of gets stuck right here within the lumen, which is connecting between the cecum and the appendix. Now, when that stone gets stuck there, what happens is a bunch of pressure builds up just proximal to that actual fecal stone. So here, we'll represent that by putting like an up arrow here. We'll say here, what's happening inside of this appendix? You're having an increase in the pressure. And we'll talk about all the downstream effects of having that increased pressure within the side of the appendix. But not only is there an increase in pressure, sometimes what happens is you have bacteria that naturally sit. They're part of our flora. There is going to be bacteria that sit in parts of your actual mucosa. If it can't get moved out, what happens to the amount of bacteria inside of the lumen of the appendix? It goes up. So another thing that you'll have is not only just an increase in pressure, but you'll have an increase in like what's called bacterial colonization. But for right now, we'll say that there's lots of bacteria. The combination of these two, which we'll go over in detail, is what really leads to the fact of appendicitis, the inflamed appendix. Now, with a fecalith, what patient population, you're reading the clinical vignette, patient comes in, we'll talk about the classic findings, they're this age. What is a fecalith age usually supposing of? It's usually more particularly seen in those that are of the infants or the young adult age. So I would think about this more, and we're just going to use the terminology of children. You're going to see this more in that younger population as the primary cause. But it's an obstruction. So the key thing here is it is an obstruction where within the appendiceal lumen that's blocking flow of particular contents out of the appendix, creating an increase in back pressure and an increase in bacterial colonization. You're going to notice the same thing out of each one of these, except in this one, a patient has what's called lymph node hyperplasia. So in other words, you're going to have a bunch of lymph nodes in the actual surrounding vicinity. But let's say that you have some lymph nodes that are just a little bit thicker, a little bit bigger, and these things are pressing on the outside of the appendix, near the actual lumen. So because of that, what's going to happen? It's going to be hard to move contents out. It'll create an increase in back pressure. And then again, bacterial colonization. So you get the same concept. I want this to become ingrained into your brain, that you'll have an increase in bacteria and an increase in the back pressure. And these two combinations will then lend to what we call appendicitis. Now, what is the particular age range or epidemiological cues that will usually make you think about this one? This is usually going to be more in the adults. So if you have an adult who comes in with that right lower quadrant pain, appendicitis signs, then you want to definitely be thinking, could it be lymph node hyperplasia? Either way, it's causing some type of obstruction, if you will, of the appendiceal lumen, leading to this high back pressure and bacterial colonization. All right, last one, straightforward, neoplasm. Now, in this, you have some type of tumor. It could be extraluminal, so you could have a tumor sitting out here, or a mass compressing on the outside, or you could have some type of mass that's intraluminal. And it's, again, obstructing the actual, what? Contents from being able to be moved out of the appendiceal lumen. So here's our obstruction. And what we know is if you have this particular obstruction here, you can't move things forward out of this appendiceal lumen, increases. What happens? It's becoming a little bit of a trend here, I believe. You're going to have an increase in your pressure, the back pressure, and an increase in what else? The bacterial colonization. Okay, now, who would you see this in, neoplasia? It's going to be usually those of older age, particularly greater than 50 years of age. So what I really want you to be looking for here is going to be that greater than 50-year-old patient. Okay? Now, with that being said, a patient comes in, they have appendicitis. They have an obstruction of the appendiceal lumen. Back pressure increases, bacteria colonize, leads to appendicitis. How exactly? Let me quickly go over that. So, this appendix here is super inflamed. Now, the reason why is, we already talked a little bit about this. Let's just say here is going to be our obstruction point. Here's the obstruction. The back pressure is going to be one of the big problems here, right? So we said, okay, here's our obstruction. It'll cause an increase in the back pressure. That's one particular thing. The other thing is that you're going to cause an increase, we talked about this one as well, and it's a pretty recurring theme that we mentioned multiple times. You're going to increase bacterial colonization. So now from this, you're going to have all kinds of stuff in here. You may have a lot of fluid, and you may have a lot of bacteria. So there's going to be a lot of bacteria. You potentially are going to have some fluid kind of sitting in here as well, because there's naturally going to be some fluid within the actual GI lumen. And so now all of this stuff is going to sit here, all right, because of this obstruction. Now, if the back pressure is really, really high, what's going to happen? You can't move this fluid and bacteria and other contents out. It's going to start distending. And so what you're going to have from this increased back pressure is you're going to have an increase in distension. And whenever you have this stretched out appendix or distended appendix, that's going to be one potential manifestation. When this sucker is really, really big, and on top of that it's inflamed and infected, it starts actually causing a lot of pain in particular areas that we'll talk about. The other thing is, as the bacteria colonize, if you have more and more of this bacteria, what happens is they can actually start causing damage to the actual appendix tissue. Now, what will happen is the appendix will start getting super inflamed because of the bacteria, which will actually start to precipitate infection. So you'll have infection and inflammation of the appendix. And now this puppy is so hot, angry, and large. So now, again, what happens here? You get increase, inflammation, and infection. And then as a result, if you inflame, infect the appendix, and stretch it out, the combination of these two is what you see in a patient who presents with appendicitis. Okay, now when a patient has appendicitis, they have an inflamed appendix, what is going to be their presentation? Well, generally what happens is whenever their appendix is super inflamed, it's going to be in that right lower quadrant. And so what they'll have what's called a migrating abdominal pain. And so it'll potentially start here in the periumbilical region, and then it'll move down to what's called the right lower quadrant. So that's one very common manifestation. The other thing is if you press in the right lower quadrant, we call this McBurney's point, or that right lower quadrant tenderness. Whenever you press on that area, it's going to elicit a lot of pain. Why? Because it's inflamed, it's big, and it's infected. The other concept is when you do specific signs, appendicitis signs, it'll really help you to think about a patient who has appendicitis. So if they come in, right lower quadrant pain, tenderness in that area, or the migrating, periumbilical to right lower quadrant, McBurney's point tenderness, and you do special tests. So you have them lay on their back, and we'll show you guys this. What you do is you have them lay on their back, kind of keep their legs straight, and what you're gonna have them do is try to flex at the hip while you're trying to give for some resistance. What that does is that really, it kind of causes a lot of pain if they have like a retrocecal appendix, but that could be one sign, all right? That's called the psoas sign. Another one is if you have them, again, they can have their knee flexed, and then what you do is you try to internally rotate around that hip, and what it can do is it can kind of smash down on that big inflamed angry appendix and precipitate pain. That's called an obturator sign. There's also other ones that can be very, very suggestive. So it's called the Rosving sign, and it's very interesting. It's kind of like whenever you press down in the left lower quadrant, like the appendix ain't there, but if you press there and it precipitates this kind of referred pain to the right lower quadrant, that could be also very suggestive of appendicitis. So again, look for right lower quadrant pain, usually migrating from a periumbilical, McBurney's point tenderness, psoas sign, obturator sign, Rosving sign. These are all very suggestive of appendicitis, which could be secondary to a fecalith, lymph node hyperplasia, or neoplasia, causing obstruction of the appendiceal lumen, increased back pressure, distension, bacterial colonization, infection, inflammation, and therefore we have this problem. Let's now talk about the complications. All right, my friends, so now we're going to talk about the complications of appendicitis. Patient comes in, right lower quadrant pain. Maybe they started off with some periumbilical pain that migrated there. They got McBurney's point tenderness. They got some of those appendicitis signs. So you're thinking, they got appendicitis. I know the potential causes. Are they young? Could be a fecalith. Are they adult age? Could be lymph node hyperplasia. Are they greater than 50? You're thinking about neoplasia. But I think some of the other things that you have to be watching out for when a patient comes in with suspected appendicitis is the downfall, the complications if that sucker bursts. And so what happens is the first thing that you want to watch out for is a perforation of the appendix. It's pretty straightforward how this is all happening. We already know that there's a lot of back pressure. We already know that there's bacterial colonization that causes what? Distension of the appendix via the back pressure, infection, inflammation via the bacterial colonization accumulating there, and you got an inflamed and angry appendix. What's really interesting is though, as this kind of accumulates more and more pustulant type of material, it'll start to really stretch and the intraluminal pressure will rise and it'll start compressing and kind of transmitting this force onto the wall of the appendix. Now, as you start to increase the actual intraluminal pressure, what this will do is this will start to squeeze a couple different things. So let's write this down. So first thing is you're going to increase the intraluminal pressure. We already know why. We have an obstruction of some sort. It's the overall concept that we've built already in the pathophysiology portion. As that pressure rises, you start causing venous compression. You start causing lymphatic compression. That causes swelling of the appendix. So you're going to get more edema, more swelling. But here's the scary thing. You see these arteries? You see how they're supposed to be supplying like parts of the appendix? What if the pressure is so high, you start compressing the arteries, pinching them off? And now these arteries are supposed to be supplying oxygen-rich blood to this tissue. They're being compressed. What starts arising? Let's say in this portion here, oxygen-rich blood is not actually being supplied. So what will start to occur here is you'll start to experience something called ischemia. So now this area, which I'm going to represent in black, is now all ischemic. So that's one potential complication that can arise. As the increased intraluminal pressure occurs, you're going to increase ischemia to the actual appendix wall. So you're going to cause ischemia of appendix. Now, this is because of why? We said this is going to be because of a couple different things. One is the pressure rises and it compresses veins. So you're going to get a couple different things that occur. You're going to get vein compression. You're going to get lymphatic compression. And all of this is going to increase kind of that edema factor, which is going to make it more swollen, increase the intraluminal pressure even more. But the scariest one that's going to cause this ischemia is going to be the artery compression. As you start to compress that artery, you're going to reduce the blood supply. And that's when it's going to cause this ischemia of the appendix. Now, here's the problem. Whenever you have ischemia of the appendix, that wall now, that tissue right there is super weak. and it's very susceptible. So now let's say, for example, if we have this area being super susceptible, so it's super ischemic, we're gonna draw it right here now. This area is all ischemic. So this was an area of ischemia right here. But now it's so weak that what happens is the walls start to erode. And as it erodes, you increase a tract that'll then form between what? Between the intraluminal, like this luminal side, and the peritoneum. And now all of this stuff, this pus material, all this like bacteria, cells, fluid, all of this will leak out. Air, which is a part of our GIT, will leak out. And that's how a perforation arises. So then you develop a wall perforation from that persistent ischemia, and then you're gonna see the downfall of this. What is that downfall? Let's come down. No pun intended. But whenever this actually occurs, we have rupture, right? We have this perforation of the appendix wall. So here's a couple different anatomical features. This is going to be the anterior side. This is the posterior side. This is the superior. This is the inferior. We're looking at the thorax here and the abdomen here separated by this red line, which is the diaphragm. All of this in pink here is your peritoneum. Your peritoneum is double layered. The parietal peritoneum, which covers the wall of the abdominal cavity, and then the visceral peritoneum, which covers the organ that's in that peritoneal cavity. This is going to perforate, and all that material that we talked about is going to enter into this peritoneum. All this material. This could be things like air. I'm just going to write a couple things here. One is it could be air. That could definitely accumulate out here. There could be some degree of fluid that accumulates out here. Or there could be bacteria that accumulate out here. But you're going to have all of these things kind of flinging out into these particular areas. Whenever a patient has this perforation, oftentimes the complications we'll talk about will be progressively as we go to the right of the board. But one of the biggest things is whenever you perforate, it produces a couple different features that I think are important to remember. One is intense abdominal pain. So usually they have, that specific right lower quadrant that migrates from the periumbilical area. That's super suggestive. But if the abdominal pain drastically increases, that could be indicative of a perforation, much more so than their usual kind of pain that they've been having. The other thing is if they're guarding or they're exhibiting what's called rigidity. So let me explain what that means. So guarding is you come to the bed, you're getting ready to palpate, they're like, no, don't touch me. Because their abdomen is so sore and so sensitive that if you touch it, they'll scream. Or if you go and touch the abdomen, because of all this kind of perforation, their abdomen could be super rigid and hard, and that could be also indicative. The other thing I would really also watch out for is especially air. When air leaks into the actual peritoneum, we call it a pneumoperitoneum, and this can be identified sometimes, especially off of imaging. And so this is not necessarily a clinical finding, it's more of a imaging finding that could be potentially found. So watch out for potential pneumoperitoneum, watch out for an increase in abdominal pain, guarding, rigidity. Another one could be even like rebound tenderness as well, where you try to push down, so they could have something called rebound tenderness. And this is basically when you try to like press down on the abdomen and then you release really quickly. Whenever you're kind of releasing, the pain is intense. And so that's kind of an interesting finding, and that's usually suggestive of perforation or related peritonitis. Okay? So that's perforation. If a patient comes in, they have that original pain that we talked about that's classic of appendicitis, and then the pain gets worse, they have rigidity, guarding, rebound tenderness, definitely think about a perforation, especially if you get an x-ray or an imaging and you see air that sits right underneath the diaphragm. That's called a pneumoperitoneum. Okay, cool. The next one. Oftentimes a perforation will progress to an abscess. So if a patient develops a perforation, this can then stimulate what process? Well, here's they've perfed. Okay? Because of the ischemia from the intraluminal pressure rising, compressing the vessels, causing ischemia, boom, wall perfor. What can happen is, literally what it sounds like. You see how these green things? These are the bacteria. they kind of try to go out and escape outside here, but they're smart. And what they do is they wall off this area here. So they escape out here. And whenever these bacteria come and escape out into this peritoneal area, and then they kind of wall themselves off. So here's going to be a kind of a mixture of pus, which is going to be cellular debris and white blood cells and bacteria and all that kind of stuff. It's going to sit out here, outside of the lumen. That's an abscess. So again, it's a perforation that leads to bacterial organization outside of the lumen. Outside the lumen. And this is the scary thing that you can see here. So this is going to be indicative of an abscess. All right. Now these are really, really nasty. What are some of the potential findings that you'll see with these patient populations? When a patient has an abscess, again, they could come in with that right lower quadrant pain. They could still have that. Sometimes this is really difficult to identify. So they could still have, let's say here, bacteria kind of comes out here into this peritoneal area and then decides to wall itself off here. So what happens here is they may have, like, if you go in the right lower quadrant and you try to palpate, if the abscess is big enough, you may be able to palpate a mass. And so one thing is you may have this right lower quadrant mass that is extremely tender. Okay, so when you kind of palpate on the area, you may feel somewhat of a bumpy area there, but again, it's usually going to be super, super tender to palpation. The other thing here is that this is bacteria, man, and bacteria naturally will precipitate cytokines. So let's say here in this blue is going to be these cytokines, and these get out into your systemic circulation. Here's your bloodstream, right? And what happens is when these cytokines that are released get kind of put out into the bloodstream, they activate your immune system. And whenever they activate your immune system, what will happen is white blood cells will start increasing in number to try to come to the area and fight off that particular infection. So you'll have white blood cells that'll enter into your bloodstream, and that's going to be one thing. So you may have an increase in your white blood cell count because they're going to try to come to this area and fight off this infection. But the other thing is, these cytokines, not only do they stimulate this process, they get out into the bloodstream, and we all know that cytokines are really good at stimulating your hypothalamus to increase your body temperature, and they may precipitate fever. And so one of the things that you want to watch out for is an increase in fever with a right lower quadrant mass and an increase in the number of white blood cells in a patient who has appendicitis. And the only way that you'll be able to identify this is usually getting imaging to find that particular abscess. It's really difficult to identify sometimes, just on physical examination. But look for these particular things. The last scenario here is a patient who develops peritonitis. It's the same exact concept. They have to perf to develop this. So if they develop a perforation, bacteria can organize outside the lumen. If they perforate as well, so let's say here we have a perforation. Same concept exists here. Perforation that occurs here. What's the problem with this? Well, again, we already talked about how things can leak out. Fluid, bacteria, air, all that kinds of stuff. Same thing, but here's the problem. We didn't talk about anything over here about that bacteria or other types of molecules or fluid, how it agitated the peritoneum. We just said it went out into the peritoneum. If this stuff gets out into the peritoneum and then starts causing inflammation of this pink layer, now we have peritonitis. Perforation and peritonitis are very, very similar. So remember, perforation can lead to a leakage. So you'll have leakage of intraluminal contents, but particularly bacteria spill into peritoneum. So you see how we kind of have like a comparison here? This is really kind of interesting. Bacteria can organize outside the lumen and not spill directly all over the peritoneum. Here, they can diffusely spread throughout the peritoneum. This will cause a walled off area like an abscess. This will cause diffuse inflammation and infection of the peritoneum. Let's come down and talk about what that would look like though. So if this bacteria, which is here, doesn't wall off, instead it spreads out here into the actual abdomen. And then as it does that, it causes inflammation of the wall of the peritoneum. This is going to be a very common thing. You're going to get all the stuff that you would have. So it's basically all the perforation findings. All right, so all the perforation findings that we discussed would be present here. That's no different. You're going to have air, fluid, bacteria that'll leak out there. So you're still going to get what kind of things here? Intense abdominal pain. You're going to have rigidity. You're going to have guarding. You can have rebound tenderness. One of the things I think that's a little bit more suggestive, though, of peritonitis is that it's inflammation of that peritoneum. And as you inflame the peritoneum, any inflammation, generally what that'll start to do is it'll cause cytokines to be released. These cytokines will then do what? Pump up your immune system, kind of try to drag in tons of neutrophils. It'll also go to your central nervous system, particularly the hypothalamus, and say, hey, lots of inflammation going on. Maybe you should kind of jack up the body's thermostat and increase the actual body temperature. So things that you may start to notice from these cytokines is an increase in the white blood cell count, an increase in the patient's body temperature like a fever. But the other thing that's going to be really, really helpful here, so here's your cytokines. All of these cytokines are really precipitating this and this, right? So it's stimulating white blood cells to come to the area to fight off the infection, stimulating an increase in body temperature to make it difficult for bacteria to survive. All of this is from the cytokines from the inflammation of the peritoneum. The last thing that I think is also important here, and this is where it gets really scary. Bacteria in the peritoneum, there's a lot of blood vessels that are in that peritoneal area. If the bacteria have an opportunity to spread into the bloodstream, now you have bacteremia. And that bacteremia could potentially lead to a systemic infection. And so that's where you really want to be careful of, because if this bacteria gets into the bloodstream, it can precipitate a patient developing sepsis. So the last thing that you want to watch out for here is potential increased risk of sepsis if the bacteria do leak into the bloodstream. So oftentimes, a patient who has peritonitis has findings of perforation, plus maybe a fever, a leukocytosis, and maybe some beginning or inkling signs of sepsis. Another thing that's really interesting is anytime you inflame the peritoneum, it aggravates all the other parts of the bowels, especially, guess what's right next to the appendix? The ileum. So oftentimes, patients can also get an ileus. So I think some of the things to watch out for these patients is watch out for perforation findings, ileus, and then cytokine-mediated types of presentations as well, such as fever, leukocytosis, and then scary signs of sepsis. Okay, now let's move into the next aspect here, which is going to be the diagnostics of appendicitis. Patient comes in, right, and you suspect that they have maybe some form of appendicitis. Maybe they originally presented with right lower quadrant pain, right, and they had appendicitis signs. All of a sudden, they're diffuse abdominal pain, rigidity, guarding, and they also have rebound tenderness. If that's the case, now I'm scared that they went from appendicitis to a perforated appendix. First thing I should do is get an abdominal x-ray. The reason why is I want to see, do they have any evidence of pneumoperitoneum? The other thing is it could happen, they could develop peritonitis. They may have peritonitis actively. What did I tell you would happen? Maybe they could have a fever, maybe they could have a leukocytosis, but what's the scariest sign? If I see a pneumoperitoneum on the abdominal x-ray, and on top of that, I find hemodynamic instability, now I'm worried that they've progressed already to peritonitis and maybe sepsis. I'm not even going to wait to do other imaging. I'm going to take this patient straight to the OR, and they need an emergency laparotomy, and we'll provide an intraoperative diagnosis at that point in time. Now, if they have no perforation features, no pneumoperitoneum, and they're hemodynamically stable, well, then I have time and I can start working this patient up. So what I'll do is I'll get one of two studies. I'll get an ultrasound, right, of the abdomen, or I'll get a CT of the abdomen and pelvis. And so what I'll do is I'll get the ultrasound really in patients who are pregnant. The reason why is I want to reduce any risk of radiation, especially with CT scans. And a child, again, I want to reduce the risk of radiation, all right, especially from the CT scan. And so I'd get an abdominal ultrasound. And these are actually pretty good. They can definitely identify areas of a lot of appendix thickening, a lot of inflammation of the appendix, distension. And so this is a really good test at being able to identify appendicitis, especially in that particular population. If the patient is not pregnant, they are not a child, okay, well then I don't have the need to really push an abdominal ultrasound. I could get an abdominal CT scan. But the other thing is, if I got an ultrasound initially and it wasn't really conclusive, I can definitely get it a CT scan. And these are pretty good because they're definitely going to be able to identify areas of a very distended and thickened appendix wall. Right? I'll also be able to identify if there's any complications like a phlegmon or an abscess. Look, you can see here where it perforated. So you'll be able to identify both appendicitis and identify the complications associated with appendicitis. And that's why I think the CT scan is just a little bit better, because it will show definitely, oh, they have appendicitis, but it can show, oh, they have like an abscess, or it shows a perforation. So it can show findings of complications, which is very helpful. All right, that's how we would diagnose appendicitis. The question comes, okay, I have a patient with appendicitis, all right, they didn't perforate, all right, so I see no evidence of perforation on their exam, so no distended no diffuse abdominal pain, no guarding rigidity, no rebound tenderness, no pneumoperitoneum, and their CT scan doesn't really show perforation. Same thing, I don't see a very high white count, a fever, a palpable mass, and I see no abscess on their CT scan. In that case, it's a straightforward, uncomplicated appendicitis. You can just go ahead and just get them to an appendectomy. It doesn't have to be emergent, but you should try to get them a laparoscopic appendectomy as soon as you possibly can. The other thing is that you want to start treating their infection. You want to clear out the infection that they may have. And so oftentimes these patients may be started on something like ceftriaxone to cover some of the gram negatives. And then oftentimes they may also be put on like metronidazole to cover a little bit more of the anaerobic bacteria that may be a part of our GI flora. So this would be started preoperatively and probably even continued postoperatively. And then you're going to remove the source of the infection, which is by the appendectomy. Now, if it's complicated, that means that they perfed or they have an abscess. If they perforated, I don't have a lot of time to be wasting on these patients and saying, oh, we'll get an appendectomy later today or tomorrow. No. They need to get to the OR immediately. So you get them on antibiotics, ceftriaxone, metronidazole, and get them to the OR as soon as possible and do an emergent appendectomy. Oftentimes this is usually laparoscopic, but in certain scenarios, maybe they have to do it open. And then what you'll do is, again, continue the antibiotics pre and post-operatively, and then you'll cut out the infected tissue. Where it may change a little bit in the complicated patient is if they have an abscess. Abscesses can cause a lot of problems. They can inflame a lot of the tissue nearby, not just the appendix, but some of the other nearby tissue, and it can muck up the area of the surgical field. So you should start antibiotics. And then since the appendix is relatively close to the abdominal wall, if the abscess is present and it's visual, sometimes you can do ultrasound or CT guided percutaneous drainage, and you can suck some of the actual infected material out. So that's your relative degree of source control. So start them on ceftriaxone, metronidazole, oftentimes a percutaneous drainage of the abscess, and then just a couple weeks later, to allow the inflammation of the appendix to start to subside a little bit, a lot of the areas of inflammation around that vicinity of the appendix to settle down, then you can go in and do an interval appendectomy. It makes the appendectomy much smoother, and it prevents the risk of recurrence of appendicitis. And that's the only big difference here. All right, my friends, that's appendicitis. I really hope that you guys enjoyed it. It made sense. And as always, until next time.